Greetings from the League of Women Voters of Portland. I hope you are managing our community's several challenges as best possible. And now I want to welcome you to the League's first civic education program to start off our new year. Thank you for joining our Zoom panel discussion on the future of healthcare. We have an exciting group of leading and experienced healthcare doctors who are experts in women's health, public health, and current healthcare challenges, including the coronavirus pandemic. The League is dedicated to making democracy work. One of our core beliefs is that democracy functions best when voters are informed about the issues and engaged in their communities. For that reason, we present programs like this to give our Portland and Multnomah County community members the opportunity to think about issues that affect all of our lives and our well-being. During the COVID-19 pandemic, our voter education presentations will be recorded and available on our website. Visit lwvpdx.org to view candidate debates, ballot measure forums, as well as our video voters guide. And use the website vote411.org for comprehensive and nonpartisan election information. Our media partner, Metro East Community Media, records our civic education panels and voter education presentations and rebroadcasts them on community access channels, as well as putting them up on our website for YouTube. Please share the link to this program with your friends and family. Our League programs are also supported by the Carol and Velma Sailing Foundation, the Weiss Foundation, the League of Women Voters of Portland Education Fund, and Metro East Community Media. We thank our speakers, moderator, and the League volunteers who donate their time and expertise in bringing these programs to you. And now I'd like to introduce our moderator for tonight's program, League member Dr. Joanna Kane. Joanna is a retired professor of obstetrics and gynecology and radiation oncology at the University of Massachusetts School of Medicine and past professor and director of the Center for Women's Health at Oregon Health and Science University. She has worked internationally in women's health, cervical cancer, and medical ethics, and successfully mentored and developed faculty in all phases of the career life cycle for over 30 years. Joanna presently works with the World Health Organization in the Global Eliminate Cervical Cancer Initiative and with the National Institutes of Health on clinical trials with human papillomavirus vaccines. Thank you, Joanna. I turn the program over to you.
Thank you, Debbie, and thank you all for joining us. Despite heroic efforts of research and public health leaders, the COVID-19 crisis has changed all our lives and brought into stark outline the failures of our healthcare structures to meet those needs, as well as putting a spotlight on the harms of disparities of access and bias in human health, made worse in a crisis. Tonight, our distinguished panelists will give us insights into the profound impact of social conditions, gender differences, and the realities of trying to get adequate health care to underserved communities. Let me introduce you to all of them, and you can read more about each one at our website. And then we will have 15-minute presentations from each of them before opening for questions. So I'll introduce them all in the order they'll be speaking. The first to speak will be Dr. David Bangsberg, an Oregon native. Dr. Bangsberg is the founding dean of the OHSU-PSU School of Public Health and a leader in the public health implications and impact of HIV and homelessness globally. He wandered the globe for his education and career to places like King's College London, Johns Hopkins for his MD, Columbia Presbyterian for residency, and has held various academic posts prior to coming home, including as director of the Harvard Mass General Global Health Team. The second to speak will be Dr. Michelle Berlin, Professor of OBGYN and Public Health at OHSU. She is the past director of the OHSU Center for Women's Health, and she focuses on health policy issues, particularly screening and prevention services, particularly for minority and disadvantaged populations. She is a leader in women's health nationally and the primary author of Making the Grade on Women's Health, a national and state-by-state report card. She completed her MPH at UC Berkeley, her MD at University of Cincinnati, and that makes her one of few fully trained OBGYN and preventive medicine specialists in the country. Our final speaker will be Dr. Divnet Kaur, who is the interim medical director of the Mid-County Clinic for Multnomah County Public Health. There, she is on the line every day finding adequate resources and support for her patients and her staff. She grew up in Wisconsin, but was wise enough to move to Eugene, Oregon during high school and attended Whitman College, OHSU Medical School, and completed a residency in family medicine at the University of Wisconsin-Madison before coming home to Oregon. Now, as a reminder to each of you, you each have 15 minutes for your presentation before we open up for questions. I'll warn you at 5 and 1 minutes before the end. And we'll start with Dr. Bangsberg. Thank you so much.
Thank you, Joanna. It's a pleasure to be here. I appreciate the opportunity to speak to you all about public health. Wow, what a time to talk about public health. And tonight, I'd like to focus our attention on the social determinants of health and how the social determinants of health have impacted health in the US before COVID, and how COVID and the challenges we're facing with forest fires and our new awareness to fight racism, is how these social determinants of health are so important now more than ever. I don't know if you know that 2019, just last year, was the first time in US history that life expectancy in the US declined not 1, not 2, not 3, but 4 years in a row. This occurs in a setting when we have the most expensive healthcare system in the world, and also the worst outcomes of any industrialized democracy. Let me say that again. Most expensive and worst outcomes. Other countries spend half as much as we do on healthcare. That means doctors, nurses, medications, surgeries, procedures, yet get better outcomes. I want to be clear, this is not a failure of our healthcare system. We have the most technically advanced healthcare system in the world and the best providers anywhere on the planet. We have the world's best healthcare system. It's not a failure of the healthcare system. It's a failure of policy. And specifically, how we invest in health. Other countries spend just as much on health as we do, but they spend it differently. For every dollar they spend on traditional healthcare or medical care, they spend $1.70 on education, on housing, on safe neighborhoods, what we call the social determinants of health. In contrast to other industrialized countries that spend $101.70 per every healthcare dollar, we only spend 56 cents per healthcare dollar on social determinants of health, about 1/3 as much as every other country in the world. Every other nation spends the same amount of money, they just spend it differently. And because they spend it differently, their people have longer, healthier, and happier lives. US health is in a crisis, and simply, there is no way to treat us out of this crisis. And that was 2019. That was all before COVID, which has really changed our world, literally. And let's talk about COVID. Our nation has not done so well. We have the most number of COVID infections on the planet and the 8th highest per capita death rate. The impact of our physical distancing interventions leading to economic loss, including job loss, homelessness, delayed educational development, hunger, depression, anxiety, substance use, domestic violence, will be at least as bad, if not worse, than the impact that the virus has on the body, and will last a lot longer. And not everybody is impacted the same. Everybody's impacted, but everybody's impacted differently. Low-income people, communities of color, and indigenous communities have been hit the hardest, and the disparities that have existed for decades, if not centuries, have been magnified several-fold by COVID. We have to do better. We have to get our economy going. We have to open up our restaurants and our shops, but people won't go to restaurants and shops unless they feel safe. I believe that the only way to mitigate the social costs of our response to controlling the virus is to decisively control transmission and control this epidemic. Europe acted in concert, and while COVID has not gone in Europe, they've been able to open things up and have maintained fewer infections. If we don't control transmission through rational, evidence-based scientific policies, we will increase the number of deaths, and we will also extend the duration and extent of our economic and social suffering. And this is happening so fast. It's mind-boggling as an infectious disease epidemiologist and public health professional to see how fast this happened. I started off as a doctor caring for people with HIV and AIDS. It took 2 decades for HIV/AIDS to make its way around the planet. It only took COVID-19 just over 2 months. AIDS was truly happening in slow motion. Why is this happening so fast? Well, first, COVID is contagious through casual contact. Simply by being in the same space near somebody is sufficient for COVID transmission. HIV didn't transmit that way. It also took a while for us to appreciate the role of asymptomatic people in the role of transmission. Other major pandemics, HIV, Ebola, MERS, SARS, make people very sick, highly symptomatic, which allowed for easier identification and isolation and control of the epidemic. We don't have that luxury with COVID-19. And it's that combination of airborne spread as well as asymptomatic infection that has led to such rapid transmission of this pandemic on the planet. Let's talk about what we've done here in Oregon. Because I think we've done a really good job in Oregon. I think it's an example of how evidence-based policy can help us move forward, control the impact of a major pandemic on our communities. Remember last March, we were scared reading the reports of New York City that we would have twice as many COVID patients requiring ICU care and ventilators than we had beds. Our first case in Oregon was diagnosed on February 28th, and our first death was on March 14th. On March 16th, Governor closed all the restaurants and ordered no public gathering of more than 25 people. On March 17th, the schools were closed. On March 18th, higher education was moved entirely online. And on March 23rd, we had our stay-at-home order. The time from the first death to all these interventions, including stay-at-home order in Oregon, was 9 days. In contrast, it took Washington 23 days and China 12. By this rapid and effective intervention, we were able to quickly bend the COVID curve starting in the second week after these interventions. And rather than overwhelming our ICU beds with COVID patients, we at max used 15 to 20%. And we've had relatively declining hospital census and ER visits. And it's because this rapid and effective evidence-based scientific intervention and policies to support it that we, as Oregonians, were able to donate 150 ventilators to New York City when they were needed most. When the governor lifted the stay-at-home order and allowed modest outside interaction and some inside interaction with small groups, also created a universal mask mandate, we saw a modest increase in infections. But this increase in infections quickly plateaued and did not surge like we saw in Texas, Arizona, and Florida, where we saw a surge before there was a control of infections. And because of this, we have the 4th lowest infection rate in Oregon in the entire nation, and the 8th lowest mortality rate of any state in the nation. And we continue to have one of the lowest infection rates to this day. I remember during these times, walking down the street, I would bike for exercise, and at 7 o'clock, I would hear people clang their pots and pans for our brave healthcare workers who are ready to respond to patients who might have become ill with COVID. And we need to celebrate those healthcare workers because they do great work, and we need them to deliver care for not only our COVID patients, but every person who needs care in all of Oregon. But we also need you, and we now need sound policy through the Oregon Health Authority. And the reason we in Oregon stayed ahead of this curve and did not overwhelm the hospitals is because we operated outside the healthcare system through sound and evidence policy. It's you who bent the curve. It's you by giving up the things you enjoy, by adhering to wearing your mask, by staying home and limiting COVID transmission. You bent the curve in partnership with the Oregon Health Authority and other public health leaders. And so when you hear those pots and pans, cheer on our healthcare workers, but I want you to cheer on yourself because we are where we are in controlling COVID in Oregon because of you.
5 minutes.
Question is, thank you. Questions, how long will this last? Vaccine data looks really good. It's very promising thus far. And I think there's excellent likelihood that could have a vaccine in early 2021. But just when we have a vaccine, that's when the real work just begins. Because a vaccine is important, but we need to work out supply and distribution of a vaccine, which is going to be much more complicated than scaling up testing. And we'll also need to work on vaccine acceptance because we have important work to do in that area, especially here in Oregon. So I believe that we will live with this for most of 2021. Hopefully we will live with control of this transmission, limiting the number of infections and number of deaths such that each person who needs care gets the very best care they can. But we're not only dealing with COVID, we're also facing here in Oregon and around the nation centuries of harm caused by racism and coming to terms with the deaths of George Floyd, Ahmaud Arbery, Breonna Taylor, Tamir Rice, Jacob Black, Daniel Prude. And closer to home here on our own PSU campus just last year, the killing of Jason Washington. And countless others, people of color who have died before we all carry video cameras in our pockets. We are also, as we speak, facing the impact of climate change in real tragic ways. 1 of 10 Oregonians have faced potential evacuation. Thousands lost everything they have. Everyone is breathing toxic air that seems to linger forever. When I returned to Portland after growing up here 4 years ago, I thought that fighting homelessness would be the call to action. It still is, and it still needs to be, along with fighting opiates, depression, suicides. These problems haven't gotten any better. But COVID, facing racism, and the forest fires due to climate change have all gotten worse and are equal, if not equally important, and needs urgent aggression. It needs urgent attention. I don't know about you, but I find this really exhausting. You may ask, when's it going to get better? Well, It will get better. While there's no way to treat us out of this crisis, there's no magic medicine or procedure that's going to fix this. We hope for a vaccine, but when we get that COVID vaccine, the work is just beginning to scale up that vaccine. We have a lot of work to do on all these fronts, both the new fronts, COVID, racism, climate change that we're facing today, but also homelessness and substance use, depression, suicide. And while there's no magic treatment for these, we can make a difference. Because the last time we saw a public health crisis where US mortality declined, like we've seen, was in 1993 due to HIV/AIDS. That's when I was becoming a young doctor in medical school. And at that time, a person diagnosed with HIV/AIDS had 6 months to live. This, like COVID, affects marginalized and stigmatized people with the worst. And like COVID, like racism, like climate change, our initial response to HIV/AIDS was based out of ignorance, fear, and denial. We just hoped it would go away, or didn't want to face it or recognize the importance. But scientists and public health practitioners, clinicians, community mobilizers, educators came together for a national, eventually global response to call attention to the problem, to insist on resource allocation, insist on solutions when there seemed to be none. We invested in science, advocacy, education. In 20 years, we turned the HIV epidemic around from a certain death sentence to now more than 70 million people are living normal life expectancies with HIV worldwide. We did this for HIV. We can do this for COVID. We can do this to fight racism, and we can do this to fight climate change. We need to conquer today's healthcare crisis in the same way. We're doing this successfully with COVID in Oregon. We're bringing people together across disciplines, clinicians, scientists, public health practitioners, community mobilizers to invest upstream, and not just to treat disease, but promote health through scientific discovery, policy, and advocacy.
Time.
Every day, my faculty and I interact with 1,600 bright, committed, inspired students who want to take these issues on. We have the most diverse student body in Oregon. They want to take on these problems and take on the problems that our generations and generations before us created. They are our hope or future, and I know our future is bright. I'm in to support them. I am all in, and I hope you are too, because when we all come together, including our youth, we can solve these problems. Thank you.
Thank you so much. I feel better than I have all day. And now I'm going to turn it over to Dr. Berlin. You're on mute.
Yes, you're right. I was on mute. See, I was trying to be polite. Okay. So I'm delighted to speak with you as well. And I have the ubiquitous PowerPoint here. So I'm going to share my screen and let you all be able to see that. And let's get it going. Okay. So, again, I'm delighted to be talking to you today and talking to you with you about the future of healthcare for women and some of the lessons from COVID-19. And fortunately for me, Dr. Bangsberg emphasized the biggest points that I thought were important. So I am going to be underscoring them, and hopefully he'll agree that I did. So we can talk about COVID-19, some of the medical care and lessons have learned from that. I wanted to make sure you all knew about a particular definition of health that came out 25 years ago now, and talk a little bit about public and population health. Now we're going to talk about public and population health in this time, focusing on women, though all of this applies to men. And sex and gender are important issues, and I am not going to address different aspects of that. We're going to take this as women as a whole, and we can talk later about why I'm doing it that way. So in preparing for this talk, I was delighted to be able to find some current literature in The Lancet, which is one of our most prized publications in medical science from the UK. And there was someone there who said, when you're thinking about a pandemic, you have to differentiate between what comes from being infected and what comes from being affected. And we'll get to what some of the differences are. So in terms of medical aspects of care, I know that a lot of people worry about this, and there's some important aspects. I want to walk you through a little bit about some things in obstetrics and gynecology, and then we'll go beyond that. So in obstetrics and maternity care, there are 3 areas that are worth talking a little bit about, and part of that is because of the lessons learned and what things have come from this that we're going to continue to do. So I was talking to a friend of mine, Jenny Leslie, who works at Virginia Garcia and a couple of other places, all combined. And she's from the South and sometimes comes up with these wonderful expressions. So this one was, babies keep coming and people don't stop having sex, both of which are true. And I think because the reason that particularly pertains here for that first part is that when we talk about all the different kinds of health services that go on, and I know Dr. Kaur is probably going to talk about how some of that has affected what she and her colleagues are doing, you can't stop babies from needing to be born. And so acute services really have to keep going. And we've learned a lot about supply chain issues and about staffing. If anything, you need more people, not fewer. So several different things about that. There was a lot of discussion about whether women should have COVID-19 testing before they come to the hospital for delivery. And there's been different schemes that have been devised about this over the last few months. For women who are having a scheduled cesarean section, for example, since they know what day they're expecting that to happen, they've been able to have women get tested a couple of days before. But it gets complicated about what to do. But just to show you, there was a lot of discussion about what's the best way to manage that. And part of the reason is for obviously the health of the mother and of the newborn, but also for staff. What level of personal protective equipment, PPE, do they need to be wearing? Another question was, will someone have a support person during labor? You know, early on, the answer was no. A woman needed to come in by herself because really we wanted to minimize anyone's exposure at all. But over time, it looked like there were safe ways to do that. And so if someone is coming in labor, they can have one companion with them, somebody who's healthy, has no evidence or symptoms of COVID, but they can do that now. But what that doesn't permit is if somebody wants to have a doula, a labor coach, in addition to their family member or friend, they can't. They have to choose between those two. Another issue is what's called masked while pushing. So during labor, at the point at which a baby is making its way through to be born, the mom has to be pushing a lot, right? And so part of the problem had been, okay, when women are pushing, they are expelling air quite a bit, right? They're drawing in air and expelling it. And so that actually could be a pretty dangerous time if someone, let's say, was asymptomatic and hadn't been tested. So we've been asking women to wear a mask. That is incredibly uncomfortable and difficult to do. So there's that issue. But there again, it's a question of, okay, what do people who are in that room need to wear? The nurses and the clinicians otherwise who are in there, what level do they need to do? So they'll wear a certain level of protective equipment while she's in labor, but they need to add additional layers once she starts to be at the point where it looks like she's going to deliver. And again, that's part of the supply chain kind of set of issues. The other thing was the idea of, did a newborn need to be separated if their mom was found to have COVID-19? And initially, babies were separated and kept together if they did have, where had been probably, they thought, exposed to COVID, but that's now changed. And because the importance of bonding and securing breastfeeding outweighs the risk of transmission. And the risk of what's called vertical transmission, transmission from mom to infant during labor or during pregnancy, it looks to be very, very small. So that's where things are there. With prenatal care, this was another interesting thing. Prenatal care, there's the usual number of visits that women try to get in. Most of them, many of them are able to do, but we had to transition as much as possible to virtual care, right? Because we wanted women not to come in to the clinic if they didn't need to. And that was successfully done for a lot of the visits. So a minimum number of visits requiring in-person were able to be devised. And so we were able to do either phone calls initially or after a while video visits, which worked exceptionally well. And I think that the patients and the providers really got a lot out of doing that. And I'll give you a particular instance in a minute. The other question being about COVID precautions for everyone when women came in to be seen at all, you know, even in the outpatient setting. And that's a set of concerns that affect anyone doing outpatient care. So what about after delivery? Well, first of all, a lot of lactation visits can be done by video visit. We have found out more and more. And so many were converted to virtual visits, and that is something that may persist, which would be great. Here you have a mom with a newborn baby and the idea of packing everything up, the kid and everything else, right, to come into the clinic to be seen when perhaps a lot of the issues she might have with lactation can be addressed virtually would be great. And so I think that that is going to maintain as much as possible. The other thing is there's a post-delivery visit, often done at 2 weeks, that really we used to ask women to come in all the time. And I did a series of these right when COVID started to come through. And I have to tell you that it was really helpful and gratifying to do these as a virtual visit. First of all, again, mom and baby didn't have to get themselves together and travel to come in. But I was able to see their environment and see them interact in a way that I couldn't otherwise. So for those of you who may know about this, it was kind of like an old-fashioned public health nursing visit. But it was really instructive, and it really looked as if the patients enjoyed that too. So that may be something that stays. And then the other issue that we always worry about is transition back to a primary care provider if someone has one. It's always been a difficult thing to be able to convey key information postpartum to a primary care provider, although places like Multnomah County do a much better job than many, and so thank you, Dr. Kaur. And it's often difficult to find a PCP who has availability if a woman who really has not been getting care from a primary care provider needs to establish care. So those are just some of the issues that have come up. Another big issue is delayed care. So now we have a population that's really worried about COVID, understandably, and they're worried about catching COVID at a healthcare facility. The chances of that are not high, but understandably, people are concerned. And so we've seen a lot of times when people have delayed getting care. So we've had now delayed waves of care, if you will. Perhaps a subacute problem or an urgent problem has become an emergency because somebody didn't come in early enough. And there are lots of cases of that, unfortunately. The other big thing is prevention. And so what about screening and early detection of, say, breast cancer with mammograms, or something that Dr. Kane and I worry about specifically, and I know Dr. Kaur would too, but about pap smears and HPV testing. What are we going to see effects later of people not having had access to those screenings? On the other hand, some types of screening have improved, believe it or not. It looks like nationally, colorectal cancer screening has gone up a bit, because people are getting what are called FIT tests, which they can do at home, mailed to them, and they seem to be completing them better. So who knew? The other thing, thank you. The other thing that matters perhaps more acutely are things like flu vaccines and other vaccines, and for children not getting their regular vaccines. But what about things that we know right now are going to be a problem? Flu. So all of those aspects of care haven't necessarily gotten the attention that we would have wanted them to. I think the biggest thing that I am hearing about from my colleagues are mental health issues. And that for people who already have depression and anxiety, it's gotten worse. And quite honestly, everybody is depressed and or anxious because of COVID, and now, of course, because of the fires. And my colleagues are telling me that they end up needing to address that anxiety or depression first before they do anything else about what that visit was intended to cover, which makes sense, but it makes it that much more difficult. One thing that we're lucky about is that there is a lot of mental health that can be provided virtually. And in fact, psychiatrists and other mental health professionals have been doing that for a while. And now we know that that's effective, and perhaps that will be able to be done more. I have heard from some of the pediatricians I work with that actually the adolescents love this. They love being able to access their provider on a screen. And in fact, they've been more forthcoming about concerns they have this way. So that's kind of interesting. But now we get to some of the larger issues, and this is part of what Dr. Bangsberg talked about. So what are some of the overarching things that are affecting the state, the country, and really the world? So Oregon as a whole will probably do better than many states because we had, Oregon Health Plan did an expansion process. We elected to do that. And so more people than in some states have access to the Oregon Health Plan. Something like 1 in 4 Oregonians before COVID were covered by this. And there's now been about 100,000 additional enrollees since March. So what we've seen often and more with COVID and all the loss of care or loss of jobs has been the loss of job associated health insurance, so that people have increased enrollment in OHP who may have had other insurance before that. And just of course, none of this addresses the healthcare needs of undocumented Oregonians, which is a whole other talk. So I'd say the things we've learned so far are essential services, like for acute care, for example, and supply chain aspects are incredibly important. I think telehealth is here for the long term, which is, I think, a good thing. And again, well implemented within the Multnomah County health system already, so that's great. And again, insurance that's linked to jobs is a problem. So now I want to take us a little bit with a lens a bit farther out. So I talked to you about a little bit about a definition of health we're going to get to in a minute, but just so you know, 2020 is this year is the 25th anniversary of the Beijing conference, which everyone in women's health knows about, something about, and it was a platform for action in women's health. And the UN came out with a policy brief in April about COVID, but here's what they had to say about what was daunting now from Beijing. So this year, and the Beijing conference had been intended to be groundbreaking for gender equity. We had hoped that there would be a lot of changes coming through, and that's not what's happening. In fact, if anything, the pandemic has deepened pre-existing inequalities, and in these areas too. And as Dr. Bangsberg had talked about, these are aspects of social determinants of health. And those matter very, very much. In fact, the Beijing definition of women's health is that health is a state of complete physical, mental, and social well-being, and not just the absence of disease or infirmity. And in fact, for women's health, they're broadening it further to talk about emotional, social, and physical well-being. Again, I bring that up because so much of what we're dealing with isn't just medical care. That's not going to solve it. There's so much more going on that we need to do. I've referenced this policy brief at the end, but just to give you a little bit, they talk about economic effects that are worldwide. In the US, I'd say in addition to those things, we have what we've been calling the double shift plus, which is where it's fallen on women more than on many men to do childcare, schooling, and the work from home and other household needs that come up. Health effects in women, there's certainly more cases and deaths in men, but reallocation of services absolutely affects women. One thing Dr. Bangsberg also brought up is gender-based violence. Domestic violence is absolutely on the rise internationally, and we're seeing more documented cases in the United States. So what I really wanted to make sure that we've covered a little bit here are some of the aspects of COVID for people who are infected and affected, changes in care, short-term and long-term. Now you've seen another definition of health. And I think the bottom line here is, once again, as Dr. Bangsberg had talked about, we need to be thinking a lot more in terms of larger structural needs and changes. The importance of coordination in teams across all types of care and beyond, and that sufficient resources are allocated. I always say that public health is what should be, most people should be thinking about public health like a utility. You don't think about it until it's not working. And that's a problem. And that has led to a lot of under investment in public health needs for years. And we're suffering that now.
Thank you.
You bet there's more resources.
Great. Okay, so our last speaker tonight is Dr. Kaur. Thank you.
Thanks, everybody. Hi, I'm Divneet Kaur. Thanks so much for having me here. And really thank you for our previous speakers. That was wonderful. So as was stated, I work for Multnomah County Public Health at the Mid-County Clinic. It's in deep Southeast Portland, 130th and Division. And it's a community health center or a safety net clinic. So we provide primary care for anyone who walks in, from prenatal care, patients with babies, patients who are babies, children, and all the way up to end of life care. And our clinic population is the most diverse in Oregon, so something I'm very proud of. It's made up of primarily refugees. We have over 90 languages spoken by our patients, and staff speaking over 30 themselves. So many of our staff have actually come in as refugees and decided to work at the clinic. So with our current patient population, the breakdown from this year showed that 23% were Latinx, 20% were Black, African, and African American, and 25% identifying as Asian. And there are clinics similar to MID all over the US, and these are called community health centers or CHCs, and they're federally funded clinics. And I want to talk a little bit about this because these came about in the 1960s, and they were driven by civil rights activists and this movement to provide healthcare to an underserved and forgotten communities in the US. So they're serving our most vulnerable populations and often where a lot of our BIPOC communities get their care. So generally these CHCs, like MID, are understaffed, under-resourced, bursting at the seams with patients. We regularly have people waiting outside our door at 7:30 in the morning. And this model of clinics translates to medical care that has limits and less options. So mostly this is around access. Overbooked primary care providers, our pharmacy has smaller formularies, only generics, and less specialty options with longer wait times. And this is because we know Medicaid doesn't reimburse well, and no insurance doesn't reimburse at all. And those are the two groups that make up most of our patients. So things are much better since the 60s, and the Affordable Care Act has definitely gotten these clinics like MID more funding. But I just wanted to highlight that this whole system was built to provide some optimal care compared to those with private insurance. And I do want to be clear, I think considering this precedent that's set, I think MID provides and Multnomah County provide wonderful care considering this. And it's hard. A lot of it is hair pulling and cursing and loopholes and calling friends, but we find a way, and we have passionate, mission-driven and creative staff, and also being in Oregon, having hospital systems that have community care funds that can help our patients. And because Oregon did expand Medicaid. And also being in a wealthy county like Multnomah, we have more community partners, particularly in the mental health world. So I can't really whine, even though I do, but we have it much better than other clinics across the country. But even so, with this leg up, our gaps here in Portland within the city are huge. So the health disparities we see like on this side of town, the west side of town, compared to east of 82nd are drastic and really they mirror big picture trends. So rates of diabetes, hypertension, high blood pressure, heart disease, prenatal complications are all higher, as well as a significant mental illness burden in the form of depression, anxiety, PTSD, and substance use disorders. And these are all driven by social determinants of health, which have been brought up a couple of times. I'm really happy that that was shared. And these are like food and shelter and education, transportation, and employment. And I think the simplest example I can think of is you can't take your blood pressure pills if you don't have a home to put your blood pressure pills in. It's one's health and prevention of illness, which is such a big part of primary care and public health, is just not a priority to an individual if they're just trying to survive the day. So the reason I bring all this up about these clinics and the history is that doing this medicine has been this alternate world for decades, and this is our starting point before a pandemic. So the last 6 months have been really hard. That's saying it lightly. COVID has definitely highlighted these disparities, as was discussed, but none of the numbers were very surprising to us. the system is not equitable, and then you added a new stress. So it's gonna highlight more of those disparities. So I had a Latinx patient last week. She lost her job because she was in the cleaning service at a hotel at the start of the pandemic. She has been out of her medications for 2 months, didn't call to schedule or ask for refills because she was desperately looking for work, doesn't qualify for Medicaid because she is undocumented, didn't think she could afford the visit or come in for labs or her medicine. So her daughter, who was 17, finally called us. She's a patient of mine too, and just telling us mom doesn't feel well. And we brought them in, explained that our system, of course, we're not going to have you pay. It's a sliding scale payment system, but there's so much distrust in the government from our undocumented patients that she didn't want to come in. And we talked to her about how our pharmacy can find her cheapest and safest options from our formulary. And we have an in-house lab where we can just do a finger stick instead of sending anything out. So there's no extra costs. So we're able to provide safe care, but it's not optimal care. It's not following all the diabetic guidelines I learned in med school and residency, but it's safe, and it's always kind of supplemented with passionate, driven, and like creative solutions. And I can think of countless patient examples like this from the last few months, and other pandemic repercussions, but I do think it's also important to talk about how this virus is really hit hard on the east side in terms of numbers. So yes, we're doing very well in Oregon, but at Mid-County, at the clinic I'm at, we are currently at a 24.6% positive rate. The state of Oregon is about 4%. We peaked at 30% at the end of July at that kind of second peak, and really haven't seen the decline that we're hoping for. And I keep saying we're just really good at testing people who are positive, but I would like that number to go down. And even by zip code, Oregon Live actually has a great resource where numbers are being tracked by zip codes. In the area east of 82nd and into Gresham, which is a lot of the catchment for our patients, has the second highest most cases per capita in Oregon, with Woodburn just taking over the lead like last month. And of our COVID positive patients, 36% of them are Latinx, 18% are African American, 3.4% are Indigenous. So those numbers right there tell you where the disparities are. And this internal clinic data is about 2,000 patients that tested positive. And this really echoes the Oregon Health Authority data, which showed that 40% of our cases in Oregon are Latinx population with higher hospitalization rate, higher morbidity and mortality in our Black and Latinx communities. So there are numerous reasons for these trends, I think mostly stemming from those social determinants that were discussed. But I really think the largest fact I've seen is that this population doesn't have the privilege to self-isolate and quarantine like the rest of us. So in the last few months, these disparities are because our patients are essential workers. My patients are the ones working in the factories, in food service, in the warehouses, delivering goods, and caregivers. They're the most exposed. And many also live in multi-generational homes. So 10 to 12 people living together with maybe 6 or 7 leaving the house to go to work in different places. That's incredible exposure risk. And we do know how COVID spreads. It's prolonged exposure in close quarters. If one person at home is positive, the likelihood everyone else is also positive. But if grandson tests positive, the 5 other people who need to work are not going to quarantine and stay home because of the financial constraints to support these larger family units. And those who did lose their jobs, like my patient I discussed, don't have emergency savings. So things that we take for granted, like hygiene products, masks, hand sanitizer, soap, these are not covered by SNAP benefits, not by food stamps. So donations are really the way people were getting these essential things, and there was a delay for that. And like we talked about before, many of these patients are undocumented and are not getting any of the stimulus money or unemployment money. Oregon did actually distribute some emergency funds to this group recently, which was wonderful. Once again, we're very lucky here. And even those who can apply for funds, they're navigating a system as English as a second or third language. And there are 1 to 2 hour waits on the phone with unemployment. And the forms are complicated. I've seen them, I promise you they're complicated. And we have 3 social workers for our 10,000 patients. So they're doing the best they can to navigate this, but a lot of people fell through the cracks. And then back to my earlier point about getting their care at these federally funded clinics. So Mid-County and Multnomah County were on a different timeline than a lot of our private practice colleagues. So I, as a public health doctor, know what needed to be done, exposure precautions need to be taken, who to test, what to test, but we didn't get the resources to do it for about a month after everyone else in the city. And like I said, I work for a local health department. My boss is the CDC. And that's where our plans and resources come from. And there was a delay there. So we had severe restrictions on who we could test because of limited resources, and not until late June was this expanded a little bit. And
5 minutes.
this was even though the data showed that the BIPOC communities had higher rates. So we should have been testing more broadly and earlier. Testing access in the city was pretty good for most of the city. I would say there was kind of a blind spot on that east side again. It was on the west side at the Expo Center, but my patient they don't have cars, and public transit is dangerous. So these pop-up sites weren't actually very helpful to us. So we had our own tent in the back of the clinic. Trying to do both primary care and COVID care is pretty hard. I think the most difficult thing that we saw was in July and August that our turnaround times, because that was at that second peak, were about 12 to 14 days for each test. So our central lab was not able to have the expensive equipment, did not have a rapid test. So we sent everything to California, where they were being flooded with tests. And we would wait 12 to 14 days to tell people their results, which is the quarantine time. So the test is moot. And that was our only way to really contain the one thing that we had. And patients and staff and myself were appropriately upset, and people stopped coming in for testing, knowing that they wouldn't be able to work while they were waiting for these results. And though this turnaround time has improved, we're still having a lot of difficulty convincing folks to come back and get tested. So in spite of all this chaos, I do think we've learned a lot. And the brief was to discuss lessons and future change. So I do want to talk about some positive stuff. But I struggle with providing practical and concrete solutions that don't involve overarching, idealistic, and expensive change, because this is not a group I need to ask to vote, but policy change is what needs to happen. We need to start treating healthcare less as a consumer product and more as a human right, because that's the ultimate solution. But until that dream is realized, I think there are things we can do locally in our response. So one thing I would look to is culturally specific outreach. A lot of the communities that were hit were not getting the same education. They're not listening to the same news or listening to the same radio. And the Latinx community doesn't trust a public health officer calling for contact tracing information, hesitant to answer questions about personal location and other family members. And the Somali community was hit very hard too. And they worship together in big families, and we need to get religious leaders involved to help disseminate information. The other thing is we need to really work with our health navigator team and our social work teams. So we need about 4 times as many of them, but for these social determinants of health, they need to be one-to-one with our positive cases to see if there's enough food and resources to get through the quarantine period and how to navigate a complicated system. And then finally, which has been hit upon by other speakers as well, is allocating these resources equitably. So CHCs like MID, we were the last to get masks, hand sanitizer, testing. And my worry is we're gonna be the last to get the future vaccine. So we know where the need lies, like let's get it to the right place. So asking local leaders and institutions to distribute to these regions and communities by need rather than the highest bidder. So there's a lot of work to be done. I'm very optimistic because people are talking about these disparities much more now in pandemic times. So I'm really thankful to be here, and thank you for letting me just rant at you for a little bit, and I would love to answer any questions. Thanks.
Thank you so much. All of you have given us more than enough to ponder here. But while we're pondering, were there things that came up that you yourselves wanted to ask one of the other speakers? And remember to unmute yourself when you make a comment.
Dr. Berlin-Lowe talked a lot about seeing patients in their homes and seeing new things. I'd just like to hear more about that in terms of what you've seen. And when you see what you've seen, and what things can we intervene on, either as a clinician or as a public health provider or a policy person, where are the levers you see when we move out of the clinic and into the home?
Well, I'm actually going to ask Dr. Kaur because they have done an incredible job of trying to leverage resources. I mean, the kinds of things that I was seeing were relatively simple. Is mom look like she's drinking enough water to help produce enough milk? You know, and did I see evidence that the surroundings looked safe? But there are a lot of other things that can be done. And when I worked for a while within the Multnomah County system a few years ago, I was incredibly impressed by what everybody's doing. So Dr. Kaur, if you don't mind, I'm going to throw that one to you.
That's fine. Yeah, I think that really this new virtual life has been, it's been interesting. I think with the population that doesn't have a lot of technology, it's been a little bit harder. So a lot of the video conferencing has been not as helpful, but a lot of telemedicine, which I think I've gotten way more out of than I thought I would. I think our no-show rate's pretty high, so it's hard for patients to come into clinic, but calling them, they'll answer the phone. It might be 5 minutes, but you can find out how that depression medicine is working for them, if there are any side effects you need to worry about, if they need refills. We can do so much more virtually than I think we thought. It's been difficult with interpreters and things like that, but overall, I do think this has opened up a whole new opportunity for the future. And we're already like making sure there are telemedicine slots in our future templates because they're helpful. And especially folks that are working 2 to 3 jobs, have lots of kids at home, can't come in, we can help serve them better by just having that available.
Great.
A follow-up question. Are you either using community health workers to do culturally appropriate care, and how is that window opening up your practice and your understanding?
Yeah, and our community health workers are incredible. I think they do most of the work. We're just kind of there to be the medicine pushers. They go to homes. I think that's been hard in COVID, but they still go. They wear their masks and they go in and have put themselves truly on the front lines. And we just need more of them. I think that's really what my takeaway is. We've been using them for all of our social determinants, and because so much income has been lost and the risk of eviction is now coming and the risk of lights off is now, all of this is happening, and we are the first call, which is amazing as a community health center. I feel like it's great that our patients call for these things, but we just don't have the bandwidth to take care of it all, and we just need more of it. But that's a solution I think we can go concretely towards.
Great. Now we have a question from the audience for Dr. Bangsberg. What's the effect of having so many asymptomatic carriers? Should we be testing more? Does it pay to test more? And do we have any clue about how much they are active in spreading the disease?
Yeah, thank you for the question. It's a very good question. I think it's taken us a while to understand the role of asymptomatic infection, but we clearly do now that it is driving much of the COVID pandemic. Up to 50%, and maybe even more, of transmission is through people entirely without symptoms. I think this means most important, and this tends to occur usually in indoor settings, but can occur in outdoor settings. I think it just really emphasizes the importance of a mask. And we've seen this in the public health data, that as people wear their masks, and transmission rates go down. And the masks are both to protect you from becoming infected and also protect you from infecting others. It works 2 ways. In the safest circumstances, 2 people outside, 6 feet apart, both wearing masks. And when we see that, transmission is quite rare. In fact, there was a study I looked at in South Korea, a hairstylist who had 150 clients and had COVID infection, but wore her mask the whole time and didn't transmit the COVID, to any of their clients. So masks are so important. I think the other thing is testing is important in terms of, once we establish control to a low level of transmission, we hope that we can replace sort of the lockdowns and sort of social physical distancing interventions with more isolated testing and contact tracing to find small pockets of infection, and to find those small pockets early to prevent those small pockets from becoming big pockets and becoming a second wave. But that requires we maintain control of transmission. We can't do that in the face of a full second wave of infection like many of the states have seen. I think we're doing a great job in Oregon. We're making progress. I think we have more progress to make, but contact tracing with selective isolation will be quite important to control asymptomatic infection, and masks.
Great. So a question for Dr. Berlin, and this is a research question. Beyond the need to include diverse populations in research, like the research around COVID-19 vaccines and around treatments, we know there's a specific challenge for what are called vulnerable populations, pregnant women that you talked about, or children or the elderly, who are often excluded from the phase 3 initial trials. And yet they are particularly in need of those therapies. How should we be addressing that conundrum with this sort of challenge?
That is an excellent question and incredibly complicated. So I think the first piece is that we need to make sure that women are included in trials and investigations of as many medications as are pertinent in general. We're learning more and more that women metabolize medications differently. There's a dose issue. There's all kinds of things that we don't know. So that matters. The difficulties with doing this kind of research, certainly in pregnant moms, is tricky. And it's tricky because no one wants to be sued if there is an outcome that's worrisome. On the other hand, we've learned that a lot of vaccines are very safe to give during pregnancy. And in fact, we make sure to give Tdap, which includes pertussis, specifically because we want to make sure that little infants after they're born are not susceptible to pertussis until they can get those vaccines. So it's complicated. It very well needs to be approached and looked at, but it's going to be a continuing area of inquiry.
Great. Dr. Kaur, you really have thought about how we can move forward. And many community members listening to this would like to be of more help in this crisis and beyond to prevent another fractured response to serious public health issues and to improve health. How do you think an average citizen might contribute to making our health system and public health system better? What could we do?
That's really hard. Thank you for the question. There are so many levels to that question. I think as an individual, of course, people need to vote because the policy level is what's going to actually change the system. I think this is a system problem, and we can donate and do the things that are super helpful, but they're just Band-Aids. We're going to put Band-Aids over everything, but the actual problem is the healthcare system is broken. So that will be fixed with policy. And that is why people should vote, which this group already does. And individually, I think thinking about local responses is great. That's why focusing on Portland and our community and seeing actually where disparities are within the city, which is why I wanted to highlight that. Asking our local officials to pool resources over to the east side. I mean, I'm clearly very biased and selfish in my request, but I think that's where the numbers are showing they need help. And when the vaccine comes, I think we should ask for it to be over there. So write to your officials, please. Let's do this.
Thank you.
Dr. King, can I add to that?
Please do.
Compliment that. Thank you for that great answer, Dr. Kaur. I also think I really appreciate your comment about working with your community-based organization that's doing frontline health. Get involved. They need the help. There's so many great ones throughout Portland metro area, but throughout Oregon. So, find someone who's doing food service or housing assistance or any type of, so many different areas. The other is I would encourage people to attend a meeting for the Oregon Health Authority. All the meetings are public. And I'm chair of the Oregon Health Policy Board, and we listen to public comment. And every meeting we have, we invite public comment. And please come speak up, say what you're concerned about, such that the Oregon Health Authority can hear what your concerns are. And I promise you, people will listen and often act on those concerns. And just a shameless plug, the OHSU PSU School of Public Health has a number of public events. We have Public Health Portland Style this Thursday talking about the media and COVID-19. Please check out our website and get involved with that too. Thank you.
Thank you. Dr. Berlin, did you want to add anything? No? Okay. You're on mute, by the way,
I
Michelle.
know, gosh, I want to thank everyone, you all for doing this, I think it's been delightful how much we've agreed as much as anything else.
Great. Well, I have one challenge for the three of you as a question. And that is that this experience, COVID, has certainly exposed major gaps in our healthcare system and policies. If you could pick one element, one policy about the structure of our healthcare right now that you could change to assure a stronger and less disparate response, what would that be and how would you change it? And any of you can start, but just one.
Increase the minimum wage.
So you're really focused on social determinants of health, the basic bedrock.
That's the upstream stuff that's going to make a difference in the end.
Okay.
If I had to choose one, I would say access to care. We just need more access to care, especially for our most vulnerable populations.
Great. Okay, David.
I would say invest in and lead with science. This is an entirely new virus that we knew nothing about. We learned about this virus so quickly. And there was, that our understanding is not perfect and it evolves, but we now know so much about this, and we know how to control transmission. We found that consistent application of science and evidence-based policy really works. It really works. And just to invest in science, to believe in science, and to act on science. Oregon's done a great job. I wish we as a nation had done better. Europe did a great job as well. Europe, is in much better shape because they had a more consistent application of its evidence-based policy.
Okay. Well, I'm going to ask if any of you has a final comment you'd like to make, and then I'm going to turn it over to Debbie Kay to close the evening. So, Dr. Kaur, we'll start with you.
I just want to thank you all for letting me be here, and sitting with two phenomenal experienced panelists is just really, it's kind. Thank you for letting me be here. I learned a lot.
You did a great job. Dr. Berlin.
I think my previous comment stands, and I think we have a whole lot of work to do, and we will work together.
Dr. Bangsford.
I just want to acknowledge that these are really challenging, difficult times for all of us. And I find a lot of optimism in that. I take great concern that not everybody's affected the same way, and some are impacted much more seriously than others, and especially communities of color and Indigenous people. But nonetheless, this is the first time in my career that because everyone feels this, everyone understands the importance of acting. Yeah. And we have the greatest challenges we ever faced in terms of climate change, racism, COVID, and all the old challenges. But because everyone gets it, I think I have more optimism than ever before that we can all come together and respond in ways that we haven't imagined. And so I thank the youth. We are counting on you. Please get involved and get engaged in School of Public Health, and together we can make a giant difference.
Thank you. Okay, Debbie, you can lead us out.
To do that. This has been an amazing presentation. I thank you all so very much for making time to join us this evening, and it's been a tremendous education. We appreciate your participation. I want to stress that the League of Women Voters is a membership organization. We would be happy to welcome our viewers to join us. Please see our membership information at lwvpdx.org. Also, we're very excited to announce that vote411.org, the information resource I mentioned earlier, is now available in Spanish. It is expected to support approximately 10 million people in the United States through Election Day on November 3rd. Having this resource in Spanish makes the information more accessible to more people. Please tell your family and friends. One day, I hope that we will have it available in more languages, but Spanish is an excellent start for many parts of the country. And one last thing, are you registered to vote? Are you sure? Go to vote411.org to check your registration status, to register or update your current registration, particularly if you've moved. The last day to register in Oregon is October 13th. Ballots will be mailed later that week. This is Debbie Kay, President of the League of Women Voters of Portland. Thank you for joining us for this presentation. Please keep well and stay safe.